Hey everyone, my name is Abby Ernest, and I am a rising second year here on the Macon campus, and I have the pleasure of introducing Dr. Anthony Kondracki today. Dr. Kondracki is a tenure-track assistant professor of the community medicine at Mercer University School of Medicine in Savannah, Georgia. He received his MD from the Jagiellonian University Medical College and his PhD in maternal and child health from the University of Maryland School of Public Health. He teaches and mentors medical students and doctoral students who are pursuing careers in rural health. His research focuses on investigating disparities in maternal health care and health outcomes using skills in advanced statistical and epidemiological methods. Please join me in welcoming Dr. Kondracki.
Okay. Good morning, everyone. Thank you for the introduction. My topic today, this morning, will be about pregnancy-related maternal mortality in the state of Georgia, timing and causes of death. We're focused on improving the health of women in the state of Georgia. Yes, like what Abby mentioned, I'm an assistant professor at the Department of Community Medicine at Mercer University School of Medicine in Savannah. And I have no financial conflicts of interest to disclose in relation to this presentation. So about this presentation. My research focuses on maternal health outcomes, mainly preterm birth and low birth weight. And I usually focus more on analyzing large national data sets and writing up their results. So my presentation today will focus on my Provost Office Research Seed Grant that I received about maternal mortality in the state of Georgia. As you all know, it's a pressing public health issue, especially here in the state of Georgia and basically throughout the southern United States. But this will kind of focus more of a narrower topic, and about like maternal mortality. You can kind of divide it into broader topics and narrower topics. And so we're going to be focusing on pregnancy-related deaths and the leading underlying causes of death. So specifically, I'll be presenting findings based on the 2016-2019 data from the Georgia Department of Public Health to better understand the scope of the problem. And results will be compared for evidence and discussed in context with current reports and other relevant literature. Okay, so for the background, so pregnancy-related deaths, what do we know about these? This term that you may hear in the literature. They are defined by the CDC as maternal deaths that occur during pregnancy or delivery and up to 365 days postpartum, resulting specifically from complications initiated or aggravated by pregnancy. About 700 women in the U.S. die during pregnancy, unfortunately, each year. This is higher compared to other industrialized and developed countries. And almost 65% of deaths occur within a year after giving birth in the puerperium or postpartum period. The pregnancy-related death in the U.S. Is unfortunately the highest among all developed countries. And as we know from the previous speaker, it's been increasing over the past 2 to 3 decades. So this kind of figure shows maternal deaths per 100,000 live births. Data, as you can see, from a long time period from 1990 to 2015. It's taken from The Lancet. And notably, the United States is an outlier among all other developed countries that you can see that are mentioned on the slide. So we have a lot of work to do and a lot to prevent the increasing rate of maternal mortality across all the states across the country. So this chart this figure also shows maternal deaths per 100,000 live births. This was taken from the Commonwealth Fund between 2015 and 2022. And again, you can see how the United States does kind of stand out among the rest of the industrialized countries, especially among the Black population. As you can see on the very right-hand side, it has especially a very high prevalence of maternal deaths. So American women, they're almost 3 times as likely as our neighbors to the north, Canadian women, to die during pregnancy and postpartum, and more than 7 times as likely to die as Scandinavian women. So more than 2.2 million U.S. women of childbearing age, specifically between the ages of 15 and 44, live in so-called maternity care deserts. So you'll come across this term as well. There's a lot of these maternity care deserts across the Deep South, especially also here in the state of Georgia. So black mothers are 2.3 times more likely to die from pregnancy-related causes compared to white mothers, especially in rural areas. So as we all know, Georgia is predominantly a rural state. Out of 159 counties in the state, 108 counties are rural. Where 93 counties are so-called, what we hear the term maternity care deserts, without a hospital and labor delivery unit. And 75 counties lack an obstetrician, gynecologist, or even a nurse midwife. So as we all know, this definitely contributes to the higher rate of maternal mortality across the state. And unfortunately, Georgia also has the highest rate of rural hospital closures in the nation. So in 2010, among Georgia's 5 hospital closures, 4 were critical access hospitals. So this kind of map shows you all the maternity care deserts throughout the state. So the gray areas all show maternity care deserts. In contrast to the blue or the dark blue areas, which in general, people have greater access to maternity care and maternity care services and prenatal care and so on. So in 2021, the state of Georgia, after the state of Louisiana, had the second highest maternal mortality rate in the US of 66.3 deaths per 100,000 live births, which was about twice the national average of 32.9 deaths per 100,000 live births. So in Georgia, the preterm birth rate is the 7th highest, and the low birth rate is the 4th highest, and the cesarean section delivery rate is the 9th highest among the nations. So as you can see, a lot of these are all risk factors for maternal mortality. Yes, the state does have a lot of these alarming statistics. So morbidity among reproductive age women across the state contributes, unfortunately, to poor maternal health during pregnancy. Unfortunately, as we can see, there are also barriers in accessing quality prenatal and postnatal care to prevent early detection, diagnosis, and treatment of conditions that may lead to unexpected short or long-term consequences to women's health in general. So for instance, in Georgia in 2013, we kind of saw that it was a total of 79 maternal deaths, and 32 were specifically pregnancy-related deaths, and 23 deaths had at least one pre-existing medical condition, such as hypertension, diabetes, or asthma. So in effect, 6 hospitals across the state in large, more populated metro areas such as Albany, Atlanta, Augusta, Columbus, here in Macon, and in Savannah, are designated as regional perinatal centers to provide advanced care for women in high-risk pregnancy. So these hospitals are just all scattered throughout the state, and they are mainly to serve women who to have high-risk pregnancies and who would be able to at least have their pregnancies treated by more experienced medical personnel. However, there's a downside to this as well, that these centers are unfortunately located just in larger cities and are just not easily accessible to women residing in remote rural areas. So there's this issue with accessibility, which is really important. Okay, so this figure also shows you where these perinatal regions are located throughout the state. As you can see, a lot of these women who are pregnant may have to travel long distances just to get access to prenatal care, which is also, of course, a huge factor contributing to the maternal mortality issue here across the state. So the CDC has what is called a Pregnancy and Mortality Surveillance System, or the PMSS, and this reported a significant increase in pregnancy-related deaths across the country from 72 deaths per 100,000 live births back in 1987 to more recently 17.6 deaths per 100,000 live births in 2019. So yeah, unfortunately, many of us just don't know what are the reasons behind this increase. So they're just unclear. However, improved reporting by adding a pregnancy, so-called pregnancy checkbox to the death certificate, making changes in coding to the causes of death and linking death records and birth certificates may have been contributing factors leading to this increase in maternal mortality rates in the last few years. So physicians, laboratories, and other healthcare providers in Georgia are required by law to report within 7 days the death of a woman who was pregnant, or within a year of the end of pregnancy by filling out a death certificate. So the reports then are reviewed by the Georgia Department of Public Health within 2 years of the date of death by the Multidisciplinary Maternal Mortality Committee. So this committee is, almost every state across the nation has what is called a maternal mortality committee, which investigates every maternal death and it kind of tries to pinpoint what are the causes behind the maternal deaths. To determine a cause of the death and of course to learn about the circumstances surrounding the death and whether the deaths could have been prevented, which very often they could have been prevented, so more needs to be focused on the prevention aspect. So in order to better understand the scope of the problem, we utilized 2016, 2019 Georgia state-level maternal mortality data. So we had a sample of 349 women obtained from the Georgia Department of Public Health and limited our analysis to pregnancy-related deaths. So we kind of narrowed this from a broad 349 women more to like a focused number of 129, which met the criteria of pregnancy-related deaths. So our research aims at investigating factors contributing to considerable inequities in timing and cause-specific of pregnancy-related deaths across factors such as race, ethnicity, socioeconomic status, and geographic location. So in our research analysis, we kind of applied two distinct population level measures. So we looked at timing, or time points, during pregnancy, 0 to 60 days, 61 to 180 days, 181 to 365 days after giving birth. Many of you may kind of wonder why were these time points classified as 0 to 60 days, for example, instead of like the World Health Organization, or WHO, classifies them as normally as 42 days. This is because in the state of Georgia, Medicaid coverage used to cover births only up to 60 days postpartum. So we also looked at causes of death selected according to frequency rank order. So we looked at the main causes of death, which include cardiomyopathy, hemorrhage, cardiovascular coronary conditions, venous thromboembolism, mental health conditions, which are also a hot topic these days, and preeclampsia or eclampsia. So this was patterned by sociodemographic groups of women and by rural and urban county of residence. So what did we find? What are our findings? So between the years 2016 and 2019, 30 or around 23% of pregnancy-related deaths occurred during pregnancy, and 63 or almost half were within the first 60 days postpartum. And so deaths they were just more common among non-Hispanic, Black, and poorly educated women in both rural and urban areas throughout the state. And about 65% of all pregnancy-related deaths were due to cardiomyopathy, hemorrhage, and cardiovascular coronary disease. And another issue which is becoming more problematic and is very often overlooked are mental health conditions. And these were common causes of death among non-Hispanic white women during pregnancy and the late postpartum. Okay, so this table shows the findings that we have. So, and in relation to timing of pregnancy-related deaths across the state, you can see the time points that we looked at. So it's during pregnancy, 0 to 60 days postpartum, 61 to 180 days postpartum, and 181 to 365 days postpartum. And we all looked at these overall characteristics of race, ethnicity, age, education, and county of residence. So you can see for yourselves what are all these, what are the results here. So yeah, so most of the women in the study sample were non-Hispanic Black, over half. They were between the ages of 25 and 34. More than half also had less than a high school education. And the vast majority of women were living or residing in urban areas throughout the state. So this table also kind of looks at the leading underlying causes of pregnancy-related deaths across sociodemographic characteristics. So the top row includes the most common causes of maternal death throughout the state. So we're looking at cardiomyopathy, hemorrhage, cardiovascular, cardiocoronary conditions, mental health, venous thromboembolism, and preeclampsia and eclampsia. And again, this was also looked at by the characteristics that we mentioned earlier. So, and this table looked at leading underlying cause of pregnancy-related death across the 4 time points that we mentioned. And on the left-hand column, you can see this was by the overall, the most common causes of maternal mortality. So you can see cardiomyopathy was nevertheless the most common cause. So, and finally, this table looked at leading underlying cause of pregnancy-related death by urban and rural county of residence. So very often we're sometimes limited with the data that we have. So the data that I had was only limited to urban and rural counties. I could not obtain any more specific data about like specific counties or specific perinatal regions across the state. But nevertheless, this kind of gives you a picture of how this looks like in relation to urban and rural counties by the overall leading causes of pregnancy-related deaths. And this figure here is like a line graph of the percentage of pregnancy-related deaths by race and ethnicity at the 4 time points that we looked at. And as you can see, like into the later stages of the postpartum period, there are more, there's even an increase among the Hispanic women as well, which may kind of signal more that, maybe we need to focus more on this particular group of women, even up to a year after they give birth. So to conclude, the burden of maternal mortality in the state of Georgia is substantial. It's nevertheless substantial. And disparities, as you can see, nevertheless, they still remain. About 85% of pregnancy-related deaths are potentially preventable, so we need to focus more on the prevention aspect of pregnancy-related deaths. And evidence from accurately collected data will help understand that the healthcare environment in which maternal deaths occur, identify root causes, and pilot interventions throughout the state and in other areas across the Deep South, which, as we mentioned earlier, are identified as maternity care deserts. Okay, thank you so much, and I'm open to any questions that you may have. So that was overall the picture of pregnancy-related deaths. Yes?
So you said that 65% of the deaths were caused by some type of cardiovascular condition. Do you think that this shows that diet plays a major role in maternal health and mortality?
So you mentioned that cardiovascular conditions, yes, they do account for 65% of deaths, and your question was if diet contributes to this. It's possible. We don't exactly know what could account, there are probably most likely several different factors. Diet could be one of them. We're also looking at what are maybe genetic factors, which would be probably more specific and would play a greater role than just diet itself. But yeah, that is a good point that you made. Maybe perhaps, limiting diet to lower fatty foods. But I think the cardiovascular conditions here are more not just the cardiocoronary conditions or like high cholesterol, but just like cardiomyopathy, which is a very often a genetic condition, not really just related to diet itself. Yes.
My question is, okay, so over the time that you care for a client over their entire practice, from start to finish, it is a relationship,
Yeah.
right? You're seeing people very often in whatever setting. Has any of the research looked at the other side from the patient standpoint to say what it is that keeps them from attending those prenatal visits?
Right.
Is there any, is that root cause? Is it, is it urban, rural? Is it just familial? Is it, what is it that prevents that regular routine check-in versus when they just show up and they're leaving?
Right. Yeah, that's a good question. I think what the previous speaker mentioned is that I think the main issue is just lack of healthcare providers and lack of transportation to any healthcare center. So a lot of women are just faced with these barriers here across the state. Another thing is that a lot of women may even be reluctant just to see a physician if their pregnancy is unwanted, for example, or unplanned. I think those are the biggest issues here that still need to be worked on to improve access to health care and improve transportation options for women, especially in rural areas, to have access to a health care provider.
I think also, a lot of clients I deal with, a lot of it is, and I don't hear it mentioned, is they are just trying to make it day to day and keep the lights on, pay the rent. I don't see that mention that a lot of the women that I personally come in contact with over the years, that is it, even though they know they're diabetic and this, but I got the lights on, I have to do this. Till we take care of that,
Right.
that's all our needs.
Yeah, I agree. Hi.
This is long ago, but my question was related to one of your previous or your earlier graphs where you stated that prior to the 1990, most of the world had similar occurrences of maternal mortality. So after 1990, was there a significant event in the United States that happened where we started to see an increase in maternal mortality specifically in the United States?
Yeah, that's a good question. So I think that, like what we mentioned earlier, is that I think it's the way that maternal mortality is overall reported. With the introduction of the pregnancy checkbox, there have been some inconsistencies in how this has been reported. And many states actually have had what is called like a staggered adaptation of the revised death certificate. That's one issue. I think another issue is, or another issue could be, perhaps in the United States specifically, you have a change in demographics, for example. You have a lot of rural hospitals which have been closing throughout the country. That has been a major issue even here in the state of Georgia as well. I think those two are the main factors contributing to it, as well as just a lack of healthcare providers in general. I think it's becoming more and more difficult for these healthcare providers to find a place to practice in rural areas because something has to kind of encourage these healthcare providers to move and practice to rural areas, which I think has kind of been very slow or almost non-existent now, right? So I think this needs to be done in order to even this could even be done to prevent the increase in maternal mortality.
Thank you.
Yes.
Do you know if patients who died from any kind of cardio events, they had previous chronic conditions, or it's a new event only discovered during the pregnancy?
Yeah. Yeah, that's also a good question. So given the data I had, we didn't have any information on the any other pre-existing conditions in the pregnant women. However, many of these women who become pregnant, before they become pregnant, they may be at a high risk for any cardiovascular conditions because of, like, say, they have a specific gene which predisposes them or increases their susceptibility to cardiomyopathy or other cardiovascular events as well. So we also have some issues like in African Americans with the weathering hypothesis, where they're undergoing discrimination. For example, they live in these high-risk areas where they undergo a lot of stress. So this may also have a negative impact on their cardiovascular health even before they become pregnant. And this may, even if they do have an inherited condition, this will accelerate their rate of, for example, cardiomyopathy. So, okay, yes.
Now that we're able to screen for some of the genes or genetic defects that cause cardiomyopathies, is there any benefit to that, or is it financially not feasible?
I think that it would be beneficial. I think, yeah, you mentioned the financial part. Would, like, health insurance policies cover this type of genetic screening? It's a good question. It probably would depend, I would think, on the health insurance policy that women may have, if she has health insurance at all. Yeah, there's maybe also lack of availability of these tests in general, which you have to travel a long distance to be tested genetically, right? This would also be another factor as well. Mm-hmm.
And I have one more question.
Yeah.
So in your study, the difference between the data from the state and the N that you chose for the study was pretty significant. So what were your exclusionary criteria?
Yeah, so what I did is that I just excluded any deaths which were not directly pregnancy related. So there are, like, criteria out there what would define a pregnancy-related death. It has to be a death which is directly related to pregnancy itself, because there are also women who may die during pregnancy, like in a car accident, for example, or a homicide, suicide, for example. So all these women were just not taken into analysis, and they were just excluded. Okay. Yes.
You had some, if I remember your data correctly, some
Yeah.
higher deaths of non-Hispanic Black women at 181 to 365 days out, which is a little bit different from the earlier sort of deaths. So what do you attribute that?
We don't know for sure based on the data I have. We can only kind of compare this to previous studies, which may show that it just could be perhaps lack of access to health care, maybe the fact that they have some untreated underlying medical condition that was just overlooked. Perhaps also to stress or any other mental health issues as well could also play a role. So we don't exactly know, but that's a good question. Mm-hmm.
Hi. So I've noticed that in some other states, they are discontinuing their pregnancy mortality surveillance system programs. So my first question is, could you speak upon that and why would that be the case? And my second question is, in this post-Dobbs time in Georgia, are you aware of any organizations or anyone who's tracking the impact of that in Georgia?
Okay. So, yeah, I think it's kind of unclear as to why exactly these pregnancy mortality surveillance systems are not in every state. I think there are some states in which they may collaborate with other states on the PMSS. And across the state of Georgia, I know that the Georgia Department of Health is generally does keep track of all pregnancy-related deaths. I don't know of any other organization within the state that may keep track of the deaths. All I know for sure is that the source where I got my data from was the Georgia Department of Health, but that's all I know.
want to thank you.
Okay.
Thank you.
Thank you.